Welcome to the Hospital Medicine Unplugged podcast. Our focus today is a deep dive into Fournier's gangrene, or FGA, diagnosis that's, well, frankly, terrifying and absolutely critical. It really pushes us into urgent, life-saving mode.
It certainly does.
We're synthesizing the latest guidelines here, looking particularly at the IDSA and the WSCS recommendations. The goal is to give you, the hospitalist, a really clear, evidence-based roadmap that emphasizes speed and just decisive action.
And that speed is everything, truly.
Yeah.
We're dealing with a disease process that is just incredibly rapid, fulminant. The window for effective intervention is measured in hours, not days.
Hours.
So for the hospitalist, catching those subtle early signs, getting that management cascade rolling immediately, it's not optional, it's mandatory.
Before we jump into that cascade, maybe just quickly redefine FG for anyone who hasn't seen it recently. And why is the mortality so high? We're talking upwards of 20%, sometimes more, right? Much higher than, say, a standard intra-abdominal abscess.
Yeah, absolutely. So Fournier's gangrene fundamentally is a necrotizing fasciitis, but it's rapidly progressive, it's polymicrobial, and the critical distinction is its location.
Right, the location.
It hits the perineal region, the perianal area, and the genitals. Classically, you think of men, scrotum, penis, but it's vital to remember it absolutely affects women and even children too, although, yes, much less often.
And the infection typically starts locally, doesn't it? Like a breach from nearby.
Precisely. It usually kicks off from a localized infection that breaks through that fascial barrier. Think about a perforated anorectal abscess, maybe a UTI complication like a periurethral abscess. The reason the mortality skyrockets is this really unique, dangerous combination. You've got the tissue architecture in that area. It allows infection to just spread along fascial planes almost unimpeded.
Unimpeded spread. Okay.
And then you have this highly destructive polymicrobial synergy, multiple bugs working together, driving rapid tissue death and severe systemic toxicity.
Which brings us right back to that foundational principle, the thing we absolutely have to hammer home from the start.
Go ahead.
Prompt surgical consultation and urgent, aggressive surgical debridement. That is the absolute cornerstone, non-negotiable.
Absolutely. Every single guideline iteration, every expert consensus reinforces that mandate. Outcomes are directly, intimately tied to the time to operating room, time to OR.
You can have the perfect antibiotics.
Right. Perfect antibiotics, great resuscitation. But if that necrotic tissue, that source, remains, the patient will continue to spiral down into septic shock. Definitive source control means cutting out the dead tissue, and it cannot wait.
Okay, let's dig into the pathophysiology a bit. Understanding why it's so destructive helps explain the urgency for surgery. What makes this polymicrobial soup so different from, say, regular cellulitis?
It's all about that synergy. It's usually not just one bad actor. It's this vicious cycle driven by a mix of aerobic, coccidiosis, strep, staph, and gram-negatives like E. coli. And they're actively collaborating with anaerobes, like bacteroid species.
And that collaboration is key, isn't it? The anaerobes thrive in the low oxygen state,
Which the aerobes help create by consuming oxygen and producing gas. Exactly. They set each other up.
so they work together, and then they produce. What actually destroys the tissue?
Two main weapons. First, enzymes, specifically things like collagenases and hyaluronidases. These actively digest the subcutaneous tissue and fascia. That's how it spreads so fast.
Okay, enzymes breaking down barriers.
Yeah, second, potent exotoxins. These cause the systemic illness, the shock.
Right, the systemic toxicity.
But the pathological process that really defines this, the thing that seals the tissue's fate and explains why the clinical picture can be so misleading, it's obliterative endarteritis.
Obliterative endarteritis. Okay, let's unpack that. Sounds like it obliterates the small arteries.
That's exactly what it does. It's inflammation and then thrombosis clotting off of the small subcutaneous blood vessels.
So localized infarction.
Precisely. Profound tissue ischemia. That is the pathological hallmark of FG. And this vascular compromise is devastating because it stops antibiotics from getting to the tissue. It stops the body's own immune cells from getting there.
Creating a perfect storm for necrosis to just explode.
Exactly. Rapid, irreversible necrosis.
So if the core problem is this vascular obliteration, how does that show up clinically? Why is it sometimes so hard to spot early?
Well, that endarteritis explains why the infection often races ahead of what you see on the skin. The skin might look okay, maybe just a bit red, some erythema, but underneath, the fascia could already be dead, terminally ischemic, because those small vessels are thrombosed.
Non-viable tissue under seemingly okay skin.
Right. And that is precisely why the surgeon must debride aggressively, cutting until they hit healthy bleeding tissue. They have to go well beyond the edge of what looks visibly sick on the surface.
Understanding the bugs involved is the next piece, etiology. We know the source is usually nearby tissue. What kind of microbiology are we typically up against?
It's broad, reflecting where it starts, GU or GI tract usually. So we commonly find E. coli, Bacteroid species, various strep species, staph species, Enterococcus.
Klebsiella proteus.
Yeah, Klebsiella, Proteus species too. The key takeaway here for treatment is you absolutely need coverage for that whole spectrum. Gram-positives, gram-negatives, and anaerobes. You can't miss any piece.
And then there are the evolving challenges, MDROs, multi-drug resistant organisms. How does that complicate the initial antibiotic choice?
It forces our hand, really.
Yeah.
We have to start extremely broad empirically. We're seeing MRSA more often, which needs specific coverage like vancomycin or linezolid.
Right.
We see ESBL producing E. coli, and increasingly even really tough gram-negatives like Acinetobacter baumannii.
So for the hospitalist, if you have a patient with a history of MDROs or maybe recent hospitalization,
You have to factor that in immediately. Your empiric regimen needs to account for those threats right from the start. That often pushes you towards using a carbapenem up front rather than maybe just piperacillin tazobactam just to be safe.
And we can't forget fungi, especially in certain patients.
Absolutely critical point. We're recognizing fungi, particularly Candida species, more and more, especially in patients who are severely immunocompromised or maybe have had long hospital stays before this.
And finding Candida isn't just incidental, is it?
No, it's strongly linked to worse outcomes. So you need a low threshold to add empiric antifungal coverage, something like fluconazole or anakinumab in those high-risk groups.
Okay, speaking of high-risk patients, when we try to identify who's most vulnerable, there's a long list of comorbidities, but a few really dominate.
The single biggest one, without a doubt, is diabetes mellitus.
Especially poorly controlled diabetes.
Yes, poor glycemic control, a high HbA1c that significantly worsens the prognosis. And it's not just an association. The high blood sugar itself impairs neutrophil function, makes it harder for the body to kill bacteria, and it worsens the underlying microvascular disease, making those small vessels even more prone to thrombosis.
So the implication for us as hospitalists is huge. We're not just managing a surgical emergency, we're simultaneously managing a medical emergency, often profound hyperglycemia, maybe even DKA.
Exactly. They go hand in hand. Other major factors are obesity, which adds metabolic risk and makes surgery technically harder, chronic alcoholism, and really any state of immunosuppression.
Like HIV, cancer, chronic steroid use.
Right. All of those significantly increase risk.
Let's pause on chronic alcoholism for a second. We see a lot of that, especially with coexisting liver disease. Why does that make FG even deadlier?
Well, with chronic alcoholism, especially if there's cirrhosis, you often have baseline coagulopathy, problems with clotting.
Right. The liver isn't making clotting factors properly.
Precisely. So that makes the patient prone to potentially catastrophic bleeding during the very aggressive debridement that's needed. Plus, they often have functional immunosuppression, portal hypertension, malnutrition. Their whole system is less able to cope with septic shock and recover.
And their baseline labs might already look bad, inflating prognostic scores like the FGSI.
Exactly. Their FGSI score might be high right out of the gate because of baseline kidney or liver dysfunction, making prognosis look worse even before the infection fully takes hold.
Demographically, you mentioned it's skewed heavily towards men. Ratios up to 42.1 in some studies, usually older adults, sixth decade or so.
Correct. So these risk factors, diabetes, obesity, alcohol, immunosuppression, male sex, older age, they demand a really high index of suspicion from us, even if someone comes in with what looks like just a simple genital infection or cellulitis.
Which brings us to the clinical presentation. This is really where the hospitalist earns their keep, right? Recognizing those red flags that mean you need to pick up the phone to surgery now, maybe even before the labs are back.
This is the moment of truth.
And the cardinal early sign, the one everyone talks about, is severe pain.
That is strikingly out of proportion to what you see physically. That's classic.
If the patient is writhing, complaining of agonizing pain in the perineal area, but you look and only see a small patch of redness, alarms should be blaring.
Absolutely.
Yeah.
Because initially, it can look really subtle. Just some localized redness, erythema, maybe some swelling, a little bit of subtle induration. It's easily mistaken for simple cellulitis.
Which is why that history of disproportionate pain is so critical.
But then the progressive signs start, and that's when you know it's a true necrotizing process underway.
And they progress fast. What are we looking for then?
Rapidly advancing edema, swelling that spreads quickly. Skin discoloration is key. It goes from just red to dusky or even violaceous purplish patches. That tells you there's underlying ischemia.
Tissue isn't getting enough blood.
Right. Then you might see bullae forming, blisters.
And the really definitive local sign, though often later,
Palpable crepitus, that feeling of crackling under the skin. Subcutaneous emphysema.
gas produced by the anaerobic bacteria.
Exactly. That's a very specific, albeit sometimes late, finding. After that, you start seeing purulent discharge, often foul-smelling, and eventually black escher, which is dead, necrotic, gangrenous tissue.
And we have to remember, this infection spreads along those deep fascial planes. So what you see on the surface might be just the tip of the iceberg.
Absolutely. The superficial involvement could look confined to the genitals, but the infection might already be tracking up the abdominal wall or down into the thighs. Mapping the true extent before surgery is very difficult.
And then, of course, the systemic signs kick in fast, sepsis.
Right. These patients crash quickly. They present with fever, profound tachycardia, hypotension, signs of septic shock, altered mental status, acute kidney injury.
So if you have that combination, systemic toxicity plus localized genital or perianal pain, the IDSA guidelines basically say that's a surgical emergency, right?
Yeah.
Even if you're not 100% sure it's FG yet.
That combination is a major red flag. It mandates urgent surgical exploration, regardless of diagnostic certainty at that moment.
Okay, so given that urgency, diagnosis is primarily clinical. Bedside assessment, looking for those local red flags, pain, crepitus, and systemic instability. What's the role of imaging then? Can we use it? When shouldn't we use it?
Imaging is purely a tool to help confirm the diagnosis if the patient is stable enough and if the diagnosis is genuinely uncertain, but it absolutely must not delay surgery.
Cannot delay surgery.
The WSES guidelines are incredibly clear on this. Imaging is not mandatory in emergent cases, especially if you have high clinical suspicion or the patient is hemodynamically unstable.
Every minute in the CT scanner.
Is a minute lost where debridement could be happening? Time is critical.
Okay, but if the patient is stable and maybe the picture is a bit muddy, pain isn't totally disproportionate, maybe it's extensive cellulitis overlapping, then what's the best imaging?
Contrast-enhanced CT is the preferred modality in that scenario.
And what does CT show us?
It's very helpful for seeing the extent. It can identify subcutaneous gas, those bubbles, which is highly suggestive. It shows fascial thickening, fluid collections that might indicate deep abscesses. It really helps map out how far the infection has spread, maybe towards the abdominal muscles or down the thighs.
What about ultrasound, if CT isn't readily available?
Bedside POCUS, point-of-care ultrasound can sometimes be useful. It might detect soft tissue inflammation, maybe even pick up some of those subcutaneous gas bubbles or fluid collections. It can offer rapid confirmation at the bedside.
But the bottom line remains. If you strongly suspect FG and the patient is unstable, skip the imaging, get surgery involved immediately.
Priority is the operating room, period.
All right, let's talk labs. What are the mandatory tests we need right away? They help assess severity, track organ function, and predict prognosis.
Absolutely. Baseline CBC is essential. Creatinine to check kidney function. Electrolytes are crucial.
And specifically hyponatremia, low sodium, that's highlighted as important.
Yes, hyponatremia is a key predictor of worse outcomes. It often reflects massive fluid shifts, that third spacing from systemic inflammation.
Okay, so CBC, CR, electrolytes with a focus on sodium. What else?
Inflammatory markers, CRP, maybe procalcitonin. A blood gas is vital to check for metabolic acidosis, look at the lactate, calculate the anion gap.
And given the diabetes link.
Serum glucose, HbA1c to see their baseline control, and urine ketones are critical pieces of the puzzle. You need that full metabolic picture.
Now, scoring systems. They help us stratify risk. There's the LR-NEX score.
The laboratory risk indicator for necrotizing fasciitis, LR-NEC. It's a more general score for necrotizing soft tissue infections.
Yeah.
It can sometimes help raise suspicion early on, using parameters like CRP, WBC, hemoglobin, sodium, creatinine, and glucose.
But for Fournier specifically,
For specifically stratifying FG patients and predicting outcomes, the Fournier's Gangrene Severity Index, FGSI, is really considered the gold standard.
FGSI, what goes into that?
It incorporates clinical variables like temperature, heart rate, respiratory rate, along with key lab values including creatinine, sodium, potassium, bicarbonate, and hematocrit.
And the Quick Sequential Organ Failure Assessment, QSOFA, is also recommended.
Yes, QSOFA is simple, respiratory rate, altered mental status, systolic blood pressure, and it's great for rapid bedside assessment of sepsis severity and organ dysfunction risk.
And the point of these...
Higher scores on both FGSI and QSOFA correlate directly with increased mortality.
So for us as hospitalists, calculating these on admission, and maybe even serially, say every 6 hours or so initially.
Helps track the patient's trajectory.
Exactly. Are they getting better or worse? It guides the intensity of care we provide, and frankly, it helps frame those very difficult but necessary prognosis discussions with the family.
Okay, this brings us right to the core management strategy. 3 immediate priorities, backed by both IDSA and WSES. They have to happen almost simultaneously.
They do. These are the 3 pillars, non-negotiable, right up front. First, immediate prompt surgical consultation aiming for urgent, aggressive surgical debridement. Aggressive fluid resuscitation and hemodynamic stabilization. Get the pressure up, perfuse the organs.
And third,
immediate initiation of broad-spectrum intravenous antibiotics. Cover everything until you know more.
okay, let's focus on the surgical management first because we keep saying it's the most important.
The data is just overwhelming. Delays kill. Even delays just waiting for a transfer to another hospital. We need intervention, ideally within hours of suspecting this.
Absolutely, hours. The surgical goal is nothing less than total excision of all the necrotic tissue. This isn't a tentative surgery. The surgeon has to be aggressive, cutting widely, extending beyond what looks visibly dead on the skin, removing affected fascia until they reach healthy, well-perfused tissue that bleeds.
Because, as we said, the visible extent always underestimates the true tissue death underneath.
Always. It tracks along those fascial planes deceptively.
And it's almost never a one-time operation, is it? Repeat trips to the OR are standard.
Essential. Repeat debridement is crucial to check for any ongoing fascial necrosis. The guidelines vary slightly on timing.
WSES says maybe every 12-24 hours, IDSA maybe 24-36.
Something in that range. The key point for the hospitalist managing the patient on the floor, or ICU, between surgeries is that the patient will go back frequently. They keep going back until the surgeon is confident the infection is controlled, no more dead tissue is found, and the patient is starting to improve systemically.
And of course, they need to get tissue cultures during that first operation.
Crucial. Deep tissue cultures during the index operation are vital to guide eventual antibiotic narrowing or de-escalation once sensitivities are back.
Okay, so surgery is paramount. Simultaneously, while stabilizing, we're hitting them with empiric antibiotics. Needs to be broad, covering everything, gram-positives, gram-negatives, aerobes, anaerobes.
Absolutely. Standard recommended starting points are usually combination therapy and need something solid for MRSA and strep. That typically means vancomycin or linezolid.
Vanc or linezolid for gram-positives MRSA.
Plus, you need an agent with excellent gram-negative and anaerobic coverage.
And the choices there are?
Usually piperacillin tazobactam, Zosyn is a common choice, or a carbapenem like meropenem or imipenem, or potentially a combination of ceftriaxone plus metronidazole.
Okay, that's a key decision point for the admitting hospitalist. Zosyn versus carbapenem versus ceftriaxone and metronidazole. How do you choose, especially in a crashing patient?
It really depends on the patient's risk factors and how sick they are up front. If the patient has a known history of ESBL colonization, maybe recent broad-spectrum antibiotic exposure, or if they are presenting in just profound septic shock.
Where you can't afford to miss anything.
Exactly. In those cases, starting with a carbapenem is often the safer bet. It gives you the broadest reliable coverage against gram-negatives, including many ESBLs and excellent anaerobic coverage.
And if they're maybe slightly less critical or local resistance isn't a huge issue.
Then Zosyn is a very strong, often equivalent alternative. The ceftriaxone plus metronidazole combo is usually reserved for situations where the others aren't suitable, maybe due to specific allergies or availability.
We definitely need to highlight the specific situation with Group A strep, if that's confirmed or strongly suspected as the cause of the necrotizing fasciitis.
Vital point. If Group A strep pyogenes, is in the mix, the preferred regimen changes. It becomes penicillin plus clindamycin.
High-dose penicillin for the strep itself.
And clindamycin is added not just for its antibacterial effect, but crucially because it suppresses toxin production by the strep.
Ah, the toxin suppression effect. That's key in necrotizing infections.
It really is. Clindamycin also has activity against bacteria in the stationary phase, which is unique and helpful when bugs are multiplying so rapidly.
Okay. And circling back to the MDRO and fungal risks, how do we build that into the Empiric plan?
If you're practicing in a hospital or region with high rates of resistant gram-negatives, or if the patient is, say, neutropenic, or has a known history of Pseudomonas or Acinetobacter,
You might need to add something else.
you might need to add an aminoglycoside like amikacin, at least initially, for double gram-negative coverage. And for fungi, again, in those high-risk patients, severely immunocompromised, chronic steroids, very high blood sugar, recent transplant, you really need to consider empiric antifungals early, usually fluconazole or an echinocandin like mycofungin.
And how long do we keep these broad antibiotics going?
Generally, until the surgical source control is complete, meaning no more debridements are needed, the patient is clearly improving clinically, and they've been febrile for a solid 48 to 72 hours. Then you can think about narrowing based on cultures.
Makes sense. Now, supportive care, this is ICU level intensity from the get-go. Aggressive fluids are obviously number one.
Absolutely paramount. The tissue destruction, the systemic inflammation, it causes a massive capillary leak. These patients third space huge volumes of fluid. They often need many, many liters of crystalloid resuscitation just to maintain a reasonable mean arterial pressure.
And vasopressors are common.
Very common for those in septic shock. Frequently needing high doses of norepinephrine, sometimes adding vasopressin or other agents.
Beyond just blood pressure, what other organ systems and markers are we watching like hawks, hour by hour?
We're watching for persistent tachycardia that can be an early warning sign of ongoing sepsis or maybe missed necrotic tissue. Tracking urine output very closely for kidney perfusion. Monitoring respiratory status, often requiring mechanical ventilation.
And nutrition.
Aggressive early nutritional support is critical. These patients are in an incredibly hypermetabolic, catabolic state from the massive inflammation. They need calories and protein early to support healing.
And back to the biggest risk factor, diabetes. Glycemic control is non-negotiable.
Absolutely critical. Aiming for tight control, often needing an intravenous insulin infusion. Hyperglycemia directly impairs immune function and wound healing. Managing that glucose effectively, along with sodium and fluid balance, can honestly make the difference between life and death.
Now, a practical challenge, especially when the infection heavily involves the perineal or anorectal areas, ongoing contamination from urine or stool.
It's a huge problem. In those extensive cases, you have to strongly consider urinary and fecal diversion.
To keep the wound clean after debridement.
Exactly. It promotes a clean wound bed, prevents reinoculation of bacteria, and really facilitates healing and eventual reconstruction.
So for the hospitalist coordinating care, when do these diversion procedures typically happen? During the first surgery? Later?
Good practical question.
Yeah.
Ideally, if it's clear from the start that there's extensive anorectal involvement, performing a diverting colostomy during the index operation, along with the initial debridement, is preferred.
Get the diversion done right away to prevent immediate fecal soilage of the clean wound bed.
Right. For urinary diversion, a suprapubic catheter is generally better than a standard Foley, as it avoids the urethra, which might be involved or eroded. That's often placed early, too.
But if the patient is just too unstable initially...
Then, source control of debridement always comes first. The diversion might have to wait for the second or third trip to the OR once the patient is more stable and the full extent of contamination risk is clearer. Surgery has to prioritize life-saving debridement over diversion in an unstable patient.
Okay, let's shift to adjunctal therapies. Things used alongside the core treatment. We need to separate what has evidence from what's mostly anecdote, right? Because these should never delay surgery or antibiotics.
Absolutely critical distinction.
Negative pressure wound therapy, NPWT, or wound vacs. That seems to be the one adjunct with pretty good support.
Yes, NPWT has a solid role, but importantly, it's used after adequate surgical source control is achieved. You can't put a wound vac on dead tissue.
Right, debridement first, then the vac.
Exactly. Once the wound is clean, NPWT is excellent for managing those huge defects left after debridement. Studies and meta-analyses suggest it helps promote granulation tissue formation, it reduces the wound size, manages exudate, and it might even be associated with a possible reduction in mortality.
Yeah.
It definitely helps bridge the gap towards eventual skin grafting or flap reconstruction.
Okay, so NTWT is useful post-debridement. What about things like hyperbaric oxygen, HBO, or IV immunoglobulin, IVIG? We sometimes hear about those.
Yeah, they pop up in case reports, small series, but they're simply not recommended for routine use.
Guidelines are pretty clear on that.
Both IDSA and WSES state that the current evidence is insufficient to support using them routinely. Specifically for HBO, the data is still limited to mostly lower quality studies. And the major concern is the logistical challenge and risk of moving a critically ill, unstable patient to a hyperbaric chamber. That delay in potential redebridement or ongoing critical care far outweighs any unproven benefit.
So focus on the basics. Surgery, antibiotics, support. Don't get distracted by unproven adjuncts that delay care.
Precisely. They must not interfere with or delay the core proven therapies.
Okay, so the patient is in the ICU, post-op day 1 or 2 after the first debridement. Monitoring needs to be relentless. Serial exams are key.
Absolutely. Vigilant, repeated clinical assessments by both the surgical and medical teams multiple times a day. You're looking for any subtle signs of progression, maybe extending redness, new skin changes, increasing pain, worsening systemic toxicity.
And backing that up with ongoing labs.
Continuous lab monitoring for sepsis markers, organ dysfunction, keep tracking that creatinine, electrolytes, watch the anion gap, lactate. And as we mentioned, consider repeating the FGSI score periodically. If it's rising despite treatment, that's a very bad sign. It tells you the current interventions might not be enough. Maybe more debridement is needed sooner.
And reminding ourselves the average number of OR trips is often 3 to 4 per admission.
Sometimes more. It really highlights that this is an ongoing surgical disease until it's definitively controlled.
Looking towards the end game, unfortunately, the complications are often severe and drive the high mortality. What are the main killers?
Septic shock itself, leading to multi-organ failure. That's the primary cause of death. Respiratory failure requiring prolonged ventilation, acute kidney injury needing dialysis, liver failure.
DIC, disseminated intravascular coagulation.
Yes, DIC is a particularly grim complication, often signifies overwhelming systemic inflammation and carries a very high mortality rate.
And locally, even if they survive the sepsis, the tissue loss can be devastating.
Absolutely. Extensive soft tissue defects are the norm. That's why diversion procedures are often needed and why complex reconstruction is almost always required later.
And that local tissue loss can sometimes mean.
Sadly, yes. Depending on the extent of necrosis, orchiectomy, removal of testicles, or even partial or total penectomy, can be unavoidable consequences in men.
Secondary infections are also a big risk during that long recovery, right? Especially MDROs.
Huge concern. These patients have massive open wounds. They're often critically ill for weeks, getting multiple antibiotics. They are prime targets for hospital-acquired infections, often with resistant organisms, which further complicates management.
And you mentioned coagulopathy earlier, especially with liver disease.
Yes, baseline or acquired coagulation dysfunction is an independent predictor of mortality, makes bleeding risk higher during surgery, and indicates severe systemic illness.
So the prognosis reflects all this severity. Mortality rates consistently cited between, say, 14% and 25%, even with modern care.
That's the typical range, yes.
What factors, when you see them on admission, really scream poor prognosis?
They really align with the scoring systems and the pathophysiology. Number one is delayed surgical intervention. The longer the delay, the worse the outcome, period. High FGSI scores on admission are strongly predictive. Advanced age, significant pre-existing comorbidities, especially diabetes, and underlying renal or liver dysfunction.
Presence of MDROs.
Presence of MDROs identifies in cultures, and the development of coagulation dysfunction during the illness. Those are also very grave prognostic signs.
And for the survivors, it's usually a long, hard road back.
It really is. Most survivors face prolonged hospitalizations. The median stays reported are often in the range of 9 to 18 days, but can be much longer. Multiple surgeries are the norm, as we said. And then, almost invariably, they require complex reconstructive surgery down the line. Things like split thickness, skin grafts, or rotational flaps to close the massive wounds left behind and try to restore some function and acceptable cosmetic appearance.
Okay, so let's try to boil this down. For the hospitalist facing this, the critical takeaways, the absolute must-dos, really fall into those 3 pillars we mentioned. They have to start almost the second you suspect FG.
Absolutely. Pillar 1, immediate aggressive debridement. That means getting surgery involved stat, getting the patient to the OR within hours, and understanding that repeat debridements, often every 12 to 36 hours, are necessary until all necrotic tissue is gone.
Pillar 2, broad-spectrum antibiotics, immediately, covering gram-positives, gram-negatives, anaerobes. That means varac or linezolid for MRSA strep, plus broad gram-negative anaerobic coverage, often zocin or carbapenem, tailored by risk factors.
And remembering to add clindamycin if group A strep is suspected, and considering empiric antifungals in the high-risk immunocompromised patients.
And pillar 3, intensive supportive care, aggressive fluids, vasopressors for shock, early nutrition, tight glycemic control, managing electrolytes like that critical hyponatremia, watching for and treating acidosis.
That critical window for intervention is incredibly short. Minutes and hours truly matter. Every single minute counts towards saving tissue and saving life.
Which brings us to a final thought. FG really forces us to act on clinical suspicion, sometimes before we have definitive proof, especially from imaging because time is so critical. So here's something for you, the listener, to consider. Given that imaging should never delay source control in an unstable patient, how should your team surgery and medicine together coordinate that threshold? When do you pull the trigger for empirical debridement based purely on high clinical suspicion that severe pain, the systemic toxicity, even if the CT scan isn't done or isn't perfectly conclusive? How do you make that call, knowing that time equals tissue and ultimately time equals survival?